Okay, good afternoon, everyone, and thanks for joining us for today's COVID-19 update. This is the third in a series of free informational webinars we at Vachette Pathology have been hosting to try to keep the broader laboratory and pathology community abreast of some of the changes we've been seeing with regard to payer and government regulations. Today we'll be joined by Lighthouse Lab Services President John Harol, so we thank him very much for his participation. Along with John today, our featured speakers will be Mick Raich, our CEO, Vachette's Vice President of Client Services, Ann Lambrix, and myself, Alex Mitchell, the Quality Programs Coordinator at Vachette. For our agenda today, we'll be discussing changes in play, providing an overview of the current environment. We'll be looking at COVID-19 payment updates, looking at the HRSA uninsured payment portal and understanding how to get paid through that portal, taking a dive into some of the new demographic data reporting requirements being required by HHS and understanding how to comply when some of that data is difficult to obtain. We'll be looking at an update on some of the government relief programs, including the PPP and Medicare Advance payment, looking at UHC's new lab test registry, and then flipping it over to the Lighthouse side of things, we'll be taking a broader look at the current state of COVID-19 testing, specifically looking at the impact on the job market, understanding whether we're meeting the testing demand, and looking at a few other big picture items to consider. And with that, I'm going to turn it over to Mick. Just 1 second, folks. I think we're having a bit of trouble with our phone line there. Just 1 second. Go ahead and take it over.
Thank you. Sorry about that. As with anything, life's not perfect, but we're working our way through it. So let's take a look at some of the things that are taking place right now. We're not out of the woods yet when it comes to some of the changes out there. Many laboratories are back at capacity now, but the revenue's not where it should be. We're looking at revenue that's 30 or 60 days behind where it should be, and we're struggling to get into the right spot. So what we see with our practices and our labs is that they're still struggling to be where they should be. The revenue's not there. And frankly, they're not sure when it's going to play out. We're actually seeing some different health systems now shutting down elective surgeries. We're seeing some changes there. So when it comes down to looking at this, you'd like to think by the end of summer we would be back to normal, but I don't think normal's quite there yet. We have not smoothed out the process, and we're not off the X as of this time.
Well, thank you, Mick, for those opening comments. And with that, we're going to now turn over to Ann Lambrix to take a deeper dive into some of the specific issues we're seeing.
Sure, thanks, Alex. So as Mick spoke briefly about, we're not off the X. We continue to see our charges and payments in flux, and getting in the understanding of how to appropriately bill and collect COVID testing, again, continues to, I would say, change every day. So we are seeing an increase in testing, which is good. So we'll see those volumes go up. There are gating procedures set at each hospital, typically for performing surgical procedures. And so it's the question is are those tests covered? What is the medical necessity? How do we bill those? Patient comes in, they are tested for COVID, they are not symptomatic, And again, you know, how are these payers recognizing the tests that are being performed and submitted?
Yep.
Medicare does, go ahead.
Yeah, one of the things that we would think this would be a linear process, that by now we would know, are all the tests covered, are all the tests going to be paid and paid correctly? But from what we're finding, we're simply not at that point yet.
Correct, and I would say that, you know, again, the majority of these charges, the COVID tests are being paid, and you monitoring your collections, and you're not seeing probably a lot of denials. However, when we continue to see the increase of testing, either, again, the testing at the hospital for pre-surgery, or even employer testing, there are potential for denials, especially on the commercial side. And so it may, even despite the need, there may be additional legwork required for appealing. And again, that's what we're expecting, again, as we continue to see the ramp up and continue to see the additional submissions. We expect to continue to see, again, some change in policy and reimbursement process from these payers. On the uninsured program, again, the uninsured program at this point, as I'm sure all of you on this call are aware, it is a multiple step process. Again, the labs that I work with, I've seen that there has been success in reimbursement, but again, it's making sure that you are appropriately vetting those patients, as well as making sure that you're submitting the appropriate diagnosis codes, which are listed here on the slide. And again, making sure, I know I've had several billers or laboratories, they batch them in smaller groupings simply to make sure that they're not submitting hundreds of tests or claims through this portal with a rejection. My understanding is you get to submit it one time. If it doesn't go through the first time, you can't continue to submit corrections. Next slide. Some of the other things that I've seen within the last couple months with COVID testing, things to think about. We have several groups that are the labs are doing testing for nursing homes. Something that we've had to work out is to make sure that the nursing home understands that if the patient has their Part A, they are the bill, the COVID test is still included on that consolidated bill. If the patient only has Part B, then it would be submitted to the MAC. However, this is potentially state specific. There are some states where you would bill directly to the state. So again, these are things that as you work through this, we're seeing that we're having to adjust our understanding or go back and look at any potential waivers that have been applied due to the national health emergency. So long-standing processes, do they change? And again, how do we appropriately bill and get paid? And again, as I mentioned, the employees, medical necessity, employee testing. If these employees are uninsured, how do we identify these patients or these employees? How do we submit them through the uninsured portal? Do we client bill it back to the employer? So again, these are additional things to think about. Managed care, one of the questions that I had from one of the labs was, it was interesting when we were reviewing the payments by tests. So we were looking at all of our reimbursement for our COVID tests, and there were some that were paying less than Medicare. So again, keep in mind, just because you are billing or expecting to collect a certain amount, only Medicare is going to pay that $100. There are a lot of managed plans that will pay significantly less per your contract or per their allowable. So again, keep in mind of that, as well as the cost sharing. So we know that Medicare they will not have any cost sharing for COVID testing. Most plans have also adopted that policy as well. However, not all. So be aware of, again, how each plan is processing these tests. making sure that you have the appropriate diagnosis codes. We saw some of those diagnosis codes on the previous slide for the uninsured portal. One of the things that I had with a lab is the diagnosis code that was coming over on the rec was the WHO diagnosis code U07.2, virus not identified. Just for all of you on the line, the World Health Organization uses the ICD-10 CM, and we use the ICD-10, let's see, US or something like that. I apologize, I don't know it offhand, but it's not the same. So, yep, we use ICD-10 CM, and the WHO uses ICD-10. So that code is not recognized, the U07.2. So again, that is something to keep in mind. And then the final thing that I wanted to mention is watch your add-on testing. The OIG is watching for labs that are just automatically reflexing to the RPP panel or any additional respiratory tests. My understanding is you should be doing the COVID test first. If it tests negative, then you can move on to the additional respiratory tests. So watch for that. Next slide. I think this is you, Mick.
Yeah, when we look at this this requirement that's come out for all these data points for HHS, this is an interesting thing that they've asked all the labs to suddenly do. And when you look at the overall process here, you have millions and millions and millions of requisitions out there with different labs to different providers, and all of a sudden you have to ask for stuff like ethnicity and race, where this has never been something that was presented before. So we see labs trying to jump through this hoop, trying to find a spot, not only on the requisition, but if it's electronic, you got to go look at your EMR and say, do we have a spot there to put it on there? And then they want to collect all this information, and right now we're not sure how it's all going to play out. I'm sure they're looking to track different outbreaks, but the point I would make is that let's make sure going forward we do have something like this, because we're not done with COVID-19, and there will be something next year, and we're going to start tracking these outbreaks going forward. So it's time to change that EMR, so you have that. It's time to change your rec. It's time to kind of look at this as a new norm and move forward. Next slide, please.
I believe this is back to you on this one, Ann?
Yep. Yes, thank you. So the government relief programs, many of you, I'm sure, have most of this memorized by now, but I just wanted to provide some quick updates. Again, some things that we're seeing from our groups and labs that we work with. Don't forget Medicare Advance. If you've received one, the Medicare Advance is something that you had to apply. It is an advance through your MAC. They will start recouping these payments, or that advance that you received, 120 days from date of receipt. And so that recoupment process will take place, again, that the clock starts ticking at 120 days, and then it will finalize the recoupment or that advance should be paid off within 90 days. So make sure that you're watching for that if you've received a Medicare Advance. Again, as Mick started off in the very beginning of the presentation, when this started, many of you, there was a scramble of just making sure that you had sufficient funds to keep going. And so you receive these. Well, that's great, and we're going to start seeing your reimbursement should start picking up throughout the summer, hopefully. But if you did accept that advance, you're going to start seeing some of that Medicare money being taken back. So it's going to offset that increase over the next couple months. So just keep that in mind. Make sure that you're tracking that, or your biller is tracking it, or has a way to track that and reconcile those takebacks. One of the things I did want to mention is if you wish to pay that back in a different format, let's say you want to just pay it back in full, set up a different payment plan, call the helpline. And again, if you need that number, message me and I will provide that out to you. Medicare, I had a group that they ended up giving back the full amount. They ended up not needing it. They didn't want to have to bother with the recoups. So you can make arrangements. What we want to make sure we prevent is that you do not extend out, again, it needs to be paid within 210 days of receipt. So if it goes past that 210 days, they'll start taking interest. Penalties will be applied at 10%. So you want to make sure that gets paid back. At this point, that has not been extended or the interest penalty has not been reduced. Provider relief, again, we've seen multiple grants. So there was two opportunities to get that free money from HHS. You need to make sure that you've attested if you've received, for each grant that you've received from HHS, and this is different from the small balance, the SBA, you must go in and attest for each separate grant that you've received. It's the same link, the same portal that you go in and attest, but you need to make sure that you've attested. But keep in mind, this is published data. You can go into the same portal and pull up everyone that has attested. You can see how much they've received. That is published data. The PPP loan, the Paycheck Protection Program Flexibility Act was signed into law June 5th. You've seen some extension from the 8 weeks that you had to use the monies to 24 weeks. And they've also changed from the 75% of the proceeds had to be used for payroll expense, and then the additional 25 could be non-payroll. They've shifted that to 60-40. And so those are some good things that we've seen with this PPP Flexibility Act. What we've recommended is that you work with your either CPA or accountant, your lending institution, again, regarding rules and what is needed to make sure that you are successful in the to get this waived, so you don't have to. So this is Go ahead.
Yeah, one thing, it's interesting on the PPP loan. We're all trying to figure out how do we square this up, and I received something just this morning from my bank stating that the SBA still hasn't finalized the latest version of the form that we have to fill out for this. So more to come still on that. Mm-hmm.
Right, and I've seen several things where they meaning in the industry, they're speculating if this if all of the PPP will be waived. However, we're just kind of waiting. I really feel that there's a lot hanging in the air as far as how long this is going to continue to go. Okay, next slide, please. The UHC lab test registry, so this is really non-COVID related, but we thought it would be interesting to throw something in here, non-COVID related, and surprising that United Healthcare is still, with all the other things that are going on in the industry with COVID, they're still moving forward with their UHC lab test registry. So they are requiring labs to provide the unique test codes, so the order codes that is used for your tests, to be submitted to United Healthcare, and then they will require those also on the claim. So the order codes must be submitted by September 1st, and then October 1st, the order code must be included on the claims submitted, or they will be denied. We are in the process here at Vachette of trying to, we're working with United Healthcare and the lab registry group at UHC to answer several questions that we have regarding this program, as it is, we're getting numerous inconsistencies with their FAQ, and so more to follow on this.
Yeah, this is interesting that UHC would continue to push this forward and not push this until the beginning of next year, and all the news rags note that they had their best second quarter ever because basically people weren't pursuing any health care in the last 3 months. So interesting that they would take at this time to continue to push this forward.
Okay, now I'll look at just a brief overview of some of the quality reporting relief that CMS is providing. Particularly, I want to turn your attention to the MIPS exception that they have extended. So they always have an extreme and uncontrollable circumstances application for anyone who's significantly impacted by events outside of their control. That has been extended to anyone who has been impacted by the COVID-19 public health emergency. And while we're still seeking clarification on exactly what CMS would consider as a severe impact, our general assumption is that this would be pretty broad for anybody who has been doing COVID testing or is able to show that they are not able to report in a way that would be typical of a normal year. So anyone who fills out one of these applications and is approved would be eligible to completely ignore their 2020 reporting, or you could select categories and ignore those categories, and you'd receive a neutral payment adjustment in 2022. The interesting impact of this is the fact that this was the year where bonuses and penalties were set to extend out to plus or minus 9%. And now anybody who's been intimately following QPP/MIPS over the last few years has seen that the bonuses have been paltry, to say the least. That's generally been because they withhold the payments from poor performers as penalties and use those to pay out the bonus pool. Well, if a large number of people choose to opt out this year, that will mean that there are fewer to penalize and likely, again, a small bonus pool. So really, MIPS continues to be mostly a penalty avoidance program with just small bonuses available. Another reminder for any of you who haven't previously joined us, with regards to PAMA, the CLFS rates for 2021 were frozen as part of the CARES Act, so there will be no 15% reduction next year as previously scheduled. And your next reporting round for PAMA has been delayed an additional year to Q1 of 2022. Now remember, that was delayed until 2021 initially by the Lab Act, and now it's been pushed out another year. And finally, we're still waiting on the release of the proposed 2021 Medicare physician fee schedule, but so far there's been no indication that the proposed fee schedule cuts due to the E&M changes will be reduced or delayed. For any of you who aren't aware, those fee schedule cuts were going to be for specialties that don't provide E&M services, such as pathology and radiology, and were expected to reach up to 8% for those specialties. There have been a lot of pushback on this recently. CAP has joined the fight, asking for Congress to waive budget neutrality requirements. So more remains to be seen, I think, but we'll see what happens when the proposed fee schedule comes out. Mick, do you have anything you want to add on that?
Yeah, I would argue that it's already been delayed, and I think they're going to delay this if they're smart. And remember, CMS is busy with a lot of other stuff right now, so I wouldn't surprise me that if they delayed this to the end of the year, or at least the middle of the fourth quarter, maybe to put the proposed fee schedule out in the Federal Register instead of the actual fee schedule, that type of thing. All the providers, and I think the government's well aware that it's not just lab and pathology, but all the providers are struggling right now. And if you came out with an overall fee cut for some of the providers, that it would be catastrophic, they're not going to be able to recover. I mean, if you run 2 or 3 months at 20 or 30 or 40% of your volume, and then you take an 8% pay cut going forward on top of that, that would be almost too big of a cookie to swallow. So I don't think the government's going to be that onerous as we go forward.
We'll certainly see when the document comes out. And with that, I want to turn it over to John Harol.
Yes, thank you guys. Crazy times, right? I feel like I've been going to laboratory conventions for many years. We're coming up on 17 years in business, and for the last several years, all everybody talked about was PAMA, and it's crazy to be at a time when they're freezing the PAMA cuts, and that's not even like making the news, right? It's not on the top of the stack. That's like being overshadowed by everything else that's going on. So such a wild time to be part of this industry, and then just the world in general. I have to look at my wife every now and then and go, "This is crazy, right?" Like it starts to get normalized, but a lot of wild stuff going on. So I really appreciate Vachette being willing to just freely share all this information, such good information in there for everybody. And I think, it's such a benefit to be able to have access to that. My name's John Harol. I'm with Lighthouse Lab Services. I'll tell you a little bit about what we do. I'm going to try to keep it really light on that part of it, and we'll just get into kind of what's going on in the market. So we provide staffing, recruiting, lab directors, and consulting assistants to labs across the country. We've helped over 1,000 labs over the last few years. That could look like adding a line of testing or building out COVID at a lot of labs right now. So that's been one of our bigger things. We're building the largest COVID testing lab in the world right now on the West Coast, going to do 100,000 samples plus a day. And so there is some relief coming to that need, but it's still only going to make a dent in it, maybe a scratch in the surface of what we really need. And so what we do is we help get LDT set up primarily. We've got a team of lab directors that are W-2 employees. I got about 8 of those, plus 5 master's degree scientists that full-time just work on helping labs bring new lines of testing in and get it validated. We also staff labs nationwide, hospitals and reference labs. We've got a database of 170 plus thousand, looks like 180,000 now of those. And we run some of the largest social media groups of medical lab scientists in the world on Facebook and on LinkedIn. And so that's kind of a little bit about us and kind of the way we view the industry and the lens we see it through, just to give you that context. Next slide. And so I wanted to talk a little bit about the state of COVID testing, right? It seems like there's been a lot of groups going into this, a lot of labs adding testing, adding COVID testing to their menu, and groups just in general that are getting into this. We're seeing people from other industries come in. It's great. They come with really fresh eyes on how to approach this and all different ways. And I have to tell them that most of those are not allowed for whatever reason, even though common sense would seem to allow it. But for regulatory reasons, you can't do that. But we're getting there and we're guiding them to a compliant way to bring a lot of testing to this market. But there's a need for a lot more, right? So this is our current state. And by current, I mean, it's maybe a week old, this data. And it looks like we're doing about 200,000 test capacity, which is better than where we were a little while ago, last time I presented these numbers, but still a far cry from where we need to be, about 180,000 tests a day short, which is significant. And this is still without serious testing of the asymptomatic populations, right? This is just with tests that are being ordered by physicians primarily. And I think there's a lot of need out there for testing of asymptomatics. I think that dam may break eventually, where employers, universities, and schools are going to say, hey, we just need to start screening everyone. I think the price point needs to come down for that to really be feasible on large scale. And I think that's getting close to happening. We're working on a few different projects that are going to really drive down price for COVID testing. The price point is out right now. Makes it tough to test everybody, once a week or any regular cadence. And so we haven't seen many groups adopt wide scale testing of asymptomatics yet, but I think that is coming, and that's going to increase that even more. And there's some studies out that show that that's going to bring the need for testing up to closer to probably 800,000 tests a day. And so we're still got a lot to do there, a lot of work to do. Next slide. Some of the issues probably some of you are familiar with that we've seen: supply chain. This continues to be a dam that every time we patch up one area, it springs a leak somewhere else, right? So it started with the swabs were in really short supply, reagents to run the tests were in short supply, reagents to do the extraction became in short supply, the equipment itself now, especially for anything under FDA EUA, is in really short supply. Constantly pivoting and finding new ways to do this. We've helped a lot of labs with kind of unique or custom workflows in order to get around that and try to get away from the mainstream where some of those supply shortages are most critical because everybody's going for the same thing. So we usually try to advise on a workflow that is a little bit more unique. The laboratory workforce in general is short. I'm going to get into that in a little bit more detail on some coming slides, so I'm just going to leave that there. But we already didn't have enough scientists to go around. Adding more testing and different types of testing did not help that problem. Turnaround delays, LabCorp and Quest in particular are really, really far behind. I think we're hearing about 10 days on turnaround. I talked to a nursing home yesterday that was screening all their employees to see if they were positive before they interacted with the seniors, and they said they were seeing a 10-day turnaround time on the results of that test. which if you think about that makes it basically pointless, right? So you're testing somebody, you get the result 10 days later. If they were contagious, all the damage is done, right? And so we really need to get that turnaround time shortened to probably 24 or 48 hours is where everybody wants to be, but we're far from that on the average at this point. Limited access for asymptomatics. It's been tough for people to get a test. Physician orders are needed. We're going to get into that a little bit further, but that's been part of the issue too. This workflow has not been what historically has been how lab testing has been delivered to the individual. So we're having to find new ways to do that. The total market capacity is just really big, right? And so having potentially a whole country need testing is a really big problem to crack. And so that's one of those things that we're trying to figure out now, what's appropriate for employers and schools in terms of how they should test, if they should test, and how frequently they should test. And then the reimbursement, Vachette did a really good job of covering that, but that's evolved some. I think it's at a pretty good place now where most labs have figured out how they can be profitable. Most groups that we talk to, it's costing them around 50, maybe 60. I talked to some that are doing it as low as $40 per test in order to get that done. And if you're billing it for that high throughput code, you're going to be reimbursed 100. And so that leaves some margin there to make a little bit of money. So figuring out all those things. Next slide. So this is an article that came out on the 30th of June, I believe. Yeah, June 30th in the Atlantic, which I think was eye-opening and explains a lot of what we've been seeing in the market. Early on, several months ago, we saw a lot of groups rush to COVID testing, and then some of them even get set up and not be able to fill up their machine. And it was kind of head-scratching, everybody saying, all I'm hearing about is that testing is the solution, but I don't see a big wave of test demand. Not sure what's happening. We've spent all this money on equipment, and we're just not seeing employers and other groups acting on this and not seeing the testing volume that we thought. What my John Harol's hypothesis is on why is I think that LabCorp, Quest, BioReference Lab, some of these big labs really soaked up that volume pretty well. They did a solid job scaling and being able to address that. But in this article on the 30th of June, all three of those groups, which are three of the four biggest, Sonic wasn't mentioned in there, but labs out there said that they're at capacity. They don't have additional capacity for COVID. They're having a hard time getting their hands on additional equipment. Reagents to run the tests are on a long lead time, and so they're at capacity. So what we're seeing now is that as those three big buckets are overflowing, all that volume is flowing into the small and medium-sized laboratories, and now they're swamped, right? So we're starting to see them not be able to stay with capacity either. We helped set up a lab here in North Carolina and put a drive-through there, and every morning the tests are wrapped around the building, and when we close up at the end of the day, there's still cars in line. And so can't do enough testing. We're trying to add in more equipment as fast as possible. We're doing that at labs across the country, and we are scaling up. We're still not catching up to demand completely. And so I do think it makes a really good case for the need for more testing capacity. So if you're one of those groups that have been on the fence, should we add testing? Is it going to be around? I think you'll be able to fill up your machines, and I think this testing is going to be around for a long time, for the foreseeable future at least. This is not something that's going to be cleared in a week or two. I think we're looking at this through into 2021 for sure. So I guess that'd be my pitch there in that. Yeah, it's not the way I think everybody.
I agree 100%. I mean, you've been jumping in trying to help some of our groups and some of our labs build into this, and we're not gonna suddenly stop doing this kind of testing going forward.
Yep, I think we all kind of, because we've never faced this before, at the beginning wanted to think this would be a blip and we would quickly get through it, but that's not been the case. This next slide gets into what's the impact on the scientists themselves, the workers, right? And so we polled over 600 lab workers just to see, you could think or theorize that all this demand for that talent would mean that they would start getting paid a lot more and there'd be more opportunity available to them, and maybe they were able to get better benefits or better shifts or schedules or whatever. Haven't seen that play out yet, unfortunately, if you're a scientist. What we've basically seen is a lot more work shoved on the same group of people that were already spread thin, and that's come with stress and risk as well. So these crews are running ragged. They feel like some of the precautions with PPE being in short supply, that they're at risk doing this testing. So it's not a great picture. Hopefully, we'll start to make a dent in that. We're continuing to bring other people into the field. Some of the regulations on what's required to do testing, say the New York licenses, California licenses, things that had typically prevented some labor from being able to work in some labs have been relaxed. So that might help a little bit. I think the lab itself, the clinical lab, has typically been something that has not been in the spotlight. Most people don't know about the profession. Most people don't really know what clinical diagnostic labs do. I think people that went into STEM and science a lot of times were more drawn to biotech and pharma and some of those areas. And this has highlighted that. So maybe long term, we might see a surge in interest in this type of testing because the importance has been highlighted throughout this pandemic. But as of right now, people are really feeling the pain. Next slide. This slide's kind of interesting. It's showing the breakdown of the different types of testing. And so you'll see the total height of that graph, and this is compared to a baseline, is up, right? So the total testing number is now up. It's dipped, and we saw and we'll see this on the next slide a little bit, but we saw that the standard testing really went down at some points as much as 70%. COVID's come on, and in general, we're north of 120% of what we normally did in terms of lab testing. A lot of that is made up of COVID and antibody. I think that as COVID rolls off, eventually someday we'll hopefully not be testing at the levels that we are now. We should see that regular testing return to 100% as people start returning to normal routines and seeing their physicians more regularly. But I thought that was just an interesting breakdown. You'll see that 6% there for antibody testing. My hunch and prediction is that we're going to see a growth in that area. Antibody testing, there was a lot of buzz about it maybe a month or two ago, and I think people just didn't really know how to apply it and what it meant, right? So we had this antibody test. You take the test, and it would show whether you've been exposed or not. What we didn't know is if you did have the antibody, did that mean you were immune or resistant? Still don't know that for sure. And Mayo came out saying, of the testing, if you do have the antibodies, you really need the neutralizing antibodies. And all the tests that hit the market, everybody rushed to get these lateral flow kits and rapid tests out in the market, didn't test for neutralizing antibodies. There's a second wave coming. There's some groups doing some really good stuff with that, where I think we're going to see a lot of neutralizing antibody tests hit the market soon, and we're going to see some medical publications that indicate that maybe a third of people that have antibodies have the neutralizing antibodies, and that those neutralizing antibodies really do point to resistance or immunity, close to immunity to COVID. And that's going to make that test a lot more valuable. And it'll still need to be done in conjunction with a PCR or a molecular test to know whether you've been infected. Because one thing to know, and this is, I'm constantly having to talk groups down that want to use the antibody test right now, it's not a good screening tool, right? It's not, if you're currently contagious and infected with COVID, you will show up negative on the antibody test most likely, because the antibody doesn't show up for a few weeks. And so not a good tool to screen people and say, yeah, it's okay, you can return to work or you can gather. But once we're able to tie it to resistance or immunity, really helpful later to be able to say, okay, this person's been exposed, they have the neutralizing antibody, we know that they're resistant to COVID, they can now be in a position where they're potentially exposed with little or no risk. Next slide. This one just shows it a little bit of a different way, but this is the overall testing volume over time. And you see that big dip in late March to April, where the volume was really down, right? We saw that get hit pretty hard. It took a while for the COVID and antibody testing to really kick in. And so it took some time to get all the equipment up, validated, staffed, and we saw that really ramped. We see it dipping back down on this graph, which was at the end of June. I think we're going to see that kick back up. I'm not sure what was behind those numbers. We are seeing that in general, the way the statistics are being reported is somewhat questionable. Yesterday, it came out that Florida, like 22 of the labs in Florida, were only reporting the positive, which was skewing the numbers like crazy. That's just mind-blowing to me that they were reporting, almost 100% positivity rate, and nobody caught that until until now, and so I don't know how that happens, but we're still trying to figure out those numbers and get that reporting tightened up. But I think that we're going to stay above that 110% number, maybe even 120% number for a while, and it might even climb up towards 150. Next slide. Things to consider. So if you're looking to get into this, there's some regulatory that you want to be aware of to make sure that you're compliant. One of those is, can an employer, that's a big question right now, is, hey, I test my employees. Can you require that, right? You can't require a lot of healthcare tests of your employees, but this one you can. The EEOC came out and said, COVID-19 is a threat. It's a threat to your peers and the other people in the workplace. So you can require that somebody gets tested, or else they can't come back to work until they do. So that is something you can require of them. So it's good to know that that's there. The medical records, if you were to start testing and you're testing students, employees, anything like that, know that HIPAA applies here, right? So this is healthcare data. If you've got that information, you need to make sure that you're handling it appropriately. Even if you find a positive, you need to do some contact tracing to figure out what's going on in the community that you're dealing with. It can't be, hey, Linda has COVID, you guys all talk to Linda, so we need to test you. You need to redact names and be careful about how you reveal that information, because you are revealing health information of that individual. So keep that in mind. How the tests are ordered, this has been something that's prohibited a lot of people that want testing from getting it, is the physician order. Still, for the most part, needed. There's a few states that have come out and said explicitly that they do not require a medical provider signature. CMS has said it. That doesn't mean that that supersedes the state requirement, right? So for billing, you don't need the medical provider signature to get reimbursed, but still, if the state law requires that lab tests are ordered by a physician, you still need a physician signature. So know that. There's some alternative options to that. We've put together a network of physicians that are licensed in all 50 states that will write lab test orders for COVID for $5 or less per patient. So there's other networks. We're not the only one in the world doing that, but that's an option out there. I would say, if you're thinking about getting into this, I would lean towards putting a physician signature behind it. There's probably a few instances where you might not need it, but even for employer groups, universities, asymptomatics, I think you're still best to do that. You don't want to be the one providing medical advice, right? As a lab, you don't want to be saying you need this test. And so it's good to have a provider in the mix. If it's going to shed some of that liability away from you, in my opinion. So just be aware of that, research it before you go to market. And if you are going to offer it in a non-physician ordered fashion, I would make sure you do your research before you do it. I think that's all. Next slide. Yep. So that's my information. If I can be helpful in any way, if you need staff validation or anything, let me know. But I'll go ahead and I'll kick it back over to Vachette.
Thanks for that, John. Really appreciate it. And we're going to turn it right back over to Mick Rage for some closing thoughts.
John, you have some interesting things there. It's like we're on the tip of a new iceberg that's coming out. It's good to see some of the labs back up where they need to be and where they're going. 110% testing. The thing that scares me is, how long will COVID testing be paid at $100? I know I think they had that set out at one time to go till the end of the year, but I'm not sure if that'll be extended or not. And how does that look at your business model when you'll start looking at an ROI on machinery? That's an interesting play. The other thing I've been talking to different labs about, and even some health systems about testing for employer groups. Can you do a direct test? Can you get outside the billing world by saying, we'll test all your 5,000 employees for X number of dollars? There's going to be some arrangements made like that to kind of get those people tested and to figure out how to get that payment going forward. So you're going to see labs, you're contracting with big employer groups to say, hey, we're going to do this for you. Interesting thing, I had a meeting this morning on blockchain and contact tracing. So that's going to be a whole nother level of what if there as we go forward. So this fall is going to be interesting. We're not off the X. We haven't. Sure. We're still in the ambush section. So when you look at this, you kind of say, okay, can we keep cash on reserve? Can we refinance our loans? Or make sure our vendors know that, hey, you know, if something happens and all of a sudden we can't get reagents and our testing drops off, how do we handle that kind of thing? And, you know, one of the things we work hard on is treating all our clients as businessmen, and they're all facing the same challenge. We've all been given this. It's not like it's a select few. It's anybody from, you know, car makers to people that do testing to doorknobs to pizza shops. I mean, everyone is facing this what if going forward. So we work hard on working a revenue projection. We're trying to, as some of our groups are now and some of our labs are seeing decreases in certain areas, we plug that in to say, here's what your revenue is going to look like. You know, if they closed your hospital and you're not doing any elective surgeries for the next 2 weeks, how's that going to affect your revenue come September? And everyone needs to know this. So everyone should have that what if model, and even building a bigger model to say, well, if they close everything down again come October 1st, how does that look? How do we, as a business, what's our cash flow and how can we move forward at that point? Our next webinar is going to look at some of the managed care trends we're seeing out here during this issue. We're going to see some, talk about how to be that subject matter expert in your community. We're going to try to lay out, this will probably be end of August, early middle of September, try to lay out the next, 3 months and what it looks like. And John, it'd be good to have your input on some of that too. So I'll leave it with this. We're not done yet. You can't think everything's back to normal yet, because we're still trying to figure this as both as a nation and as in the world population. So we're truly not done with this. We are building the new metrics going forward, the new foundation of how we're going to do this kind of testing. And it's good we have some good people here figuring things out. Alex, back to you.
Well, thank you, Mick. I believe we were able to answer a few questions through the Q&A while we were going. We're running right up against our time limit here, so we've taken down the remainder of the questions, and any of those that we're able to address, we will follow up with the attendees that had those questions. Just want to thank everyone again for joining us today, and we hope to see you all next time.
Thanks, guys. Appreciate it.
Thank you. Thanks, John. Thanks, Alex.
All right. Thanks, everybody. Bye.
Bye.